So main project updates. Thank you all for all the ICUs who have contributed. This graph just to show we have 78 ICUs contributing to the project. Majority have contributed some data, like the NESM data in particular. Some have contributed mobility. And we start to see more VEE data coming, but there's a lot of data still need to be completed. So we really encourage everybody to pull the data. And I think by this talk today, I hope that everybody appreciate the value of having this data to make a change. So just to emphasize, completing all the data, NESM data, and also the VE data, and we should do it in a timely fashion, because this is how it will guide our change. So what I would encourage first everybody to go through the website and the account for his ICU and look at the data, and we're going to go over some examples of how to evaluate, understand what's this data mean, but you're going to hopefully find it very useful. So we're going to talk today about spontaneous awakening trial and spontaneous breathing trial. And these are part of the ABCDE bundle. So the B element refers to both awakening trial and spontaneous breathing trial, which meaning spontaneous awakening trial, in other words, is called also sedation vacation, sedation interruption, all they mean the same. Spontaneous breathing trial means weaning trial. Okay, so kind of same. Weaning trial, TPs, breast support trial, the same concept. So this is data from the NESM website, and I want you to look at this data carefully. So, so this graph is for spontaneous awakening trial compliance. And this orange line reflect all the participating ICUs in the NESM project. Okay, so spontaneous awakening trial in our patients in the ICUs, we are doing it around 50% of the time only. So in patients who should have sedation interruption, in our ICUs generally is around even less than 50%. It's like 38%. The green line, this is from one of the ICUs. The green line refers to that hospital, which has multiple ICUs, and the blue line reflects your ICU. So I access through one of the ICUs, so this will be for a particular ICU. So the first striking thing, what's the main striking thing in this graph? Is that there are many patients who should have awakening trial done, but it's not done, right? Sedation should be interrupted in many patients, and it's not being done. And this essentially across the board, all the ICU is the same, more slightly difference up and down, but really a major area that we should be focusing on if we want to make a difference. This next slide, again, this is if you access your website, you're going to see this information if you enter data, obviously. So percentage of patient days without sedation. And we're going to talk about this more. So traditionally, people believe that everybody in the ICU should be on sedation infusion. And this concept is, we are changing this concept. Many patients actually do not need to be on sedation. And this slide shows you how many percentage, how many patient days without sedation. So on average in all ICUs together is around 45% of the patient days are not on sedation, which is good. You like it to see more, but it's okay. In this ICU is 50%, in this hospital 34%. This is spontaneous breathing trial, and I know here we have in the room many respiratory therapists, and on the webinar also many respiratory therapists. This is doing a weaning trial in patients who should have weaning trial done, and the compliance across all ICUs around 45%, around 45%. So 45% of patients who meet weaning trial are getting weaning trials. The rest are not. And that's, again, that will be something to improve. So for example, this ICU has a little higher, so 55%. So I'm not going to say which ICU because that's not the point, which ICU and which hospital, that's not the point. But so this hospital ICU is better, so it will guide you, it will help you knowing where you stand compared to other units. This is spontaneous breathing trial with no sedation. And so we do without sedation, obviously. Majority of patients, some patients probably were on some sedation, but the vast majority, 80%, were not on sedation. This is percentage of patients who have RAS score between -1 to 1, which means what? Means awake. Awake. So what's a percentage of our patients in the ICUs who are awake, calm, awake, not heavily sedated? Is around 31% of patients. And we like to see this more. We like to see less sedation used, right? So we like this graph to start to see this graph going up. So each unit, each CUSP team should start to think about ways to implement a change, reducing sedation, achieving higher RAS scores, etc. This is percentage of achieving the RAS target, meaning this happens all the time. So for example, we want this patient to be mildly sedated, and you come next morning and you find him heavily sedated. Is that common? It is common. So this graph shows you the percentage of patients who have RAS score, and what's achieved is what you actually wanted. So only 30% or less even. Only 30%, the score that you wanted was achieved. 70%, typically we over-sedated the patients. So very important area. We really want to reduce sedation. Delirium assessment. This is CAM negative, which means no delirium. I'm gonna not focus too much on this one. So spontaneous awakening trial contraindication rate. So this is the percentage. Not everybody in the ICU can have awakening trial. Could have, for example, severe head injury. You cannot stop his sedation. And this slide shows you your percentage compared to your colleagues and your other units. This is the contraindication for awakening for spontaneous breathing trial. So around 20-25% of patients in the ICUs would not be candidate to have weaning trial. And these are the different contraindication for awakening trial. Even patient has seizures, for example, or alcohol withdrawal. So for some reason, this is the most number one reason for not stopping sedation, patient seizures. The green one is number 3, or number 2. Number 3, patient is, no, sorry, other is 0. So most people did not put reason. But we have some patient who has seizures, some patients has receiving neuromuscular blockers, and that's the reason for sedation. Not doing spontaneous breathing trial, many people said other. So please try to put a reason. I think it will be useful to know what's the reason. Looks like most people put no reason. So please select a reason. So what I'm gonna do now, I'm gonna go over this topic in a little more depth. How can I close this? Okay. Stop share. No, you don't need videos. Share. Share this one? Yes. Okay. So this talk is actually from a site in Society of Critical Care Medicine, and I would we're gonna put the link in the website so you can access it. A lot of great lectures. You can use it for internal education. So I'm gonna go over some of these very important points. So we're gonna talk about spontaneous awakening trial and spontaneous breathing trial. And these are some references. So we're gonna review the evidence for sedating patients too much. Huh? Have share screen? So how can I get the screen? Let's see. Sure. You share.
You share it all.
You have it now?
Yeah, it's shared.
Not here.
But ours is.
So,
Two screens.
there are two screens. Something about the screen. Share. You still have it? No, it's gone.
Yeah, but
الشيء كان على البرزنتيشن.
Right. Right. What's up?
it's the screen here was.
Where's the top? Where's the lecture? Where's the lecture? Sorry, here. No.
It's okay, but it's shared.
Can you look at this? Okay, so we're going to talk about
شغلها في سكرينز.
yes. So the goal of sedation in the ICU is to really not to keep patients heavily sedated. So the trend over years in the past, we used to consider that all patients should be heavily sedated, should be asleep completely, right, for several days. But this concept has changed dramatically, and now our main goal in the ICU is not to sedate the patient, just to keep him calm. Okay, so if that can be achieved without sedation, that's what we want, is no sedation. But if he requires some sedation, that's okay, as long as we keep the patient calm, cooperative, comfortable, no anxiety, no agitation, able to be ventilated, and also reduce his traumatic memory from the ICU. We're going to talk about this, but that doesn't need necessarily to keep him fully comatose. And there are many reasons why we should do this. So, so this is a study where they looked at patients who are receiving sedation in one of the ICUs, and they found like 32% of patients receiving sedations are not arousable. And I think I could tell you, if we do it in most of our ICUs, we'll find patients who are heavily sedated, not arousable. 22% have no motor activity. They are maybe a little arousable, but they cannot move. And 2.6% people thought that they are oversedated. But the truth is, a lot of patients were oversedated. So this is from one of the studies where study on sedation. And basically the author says that we found nearly all patients were managed with continuous sedation, infusion of opioids and sedatives. We also found that the actual practice was different from what's expected because the available clinical tools like protocols and assessment scales were not applied. So we have sedation protocols, we have sedation tools, we have assessment tools, but the truth is they are not that applied. And patients generally are sedated. So this is from different parts of the world. It's the same, it's a common problem, but it is really serious problem. And that's it's really, this is a fundamental part of the NSM project. If we're gonna make one single difference in the NSM, it's gonna be this. And why? Because deep sedation has been studied extensively, is bad. It reduces survival. So patients who are heavily sedated for several days in the ICU are less likely to survive. It's very bad. So it increases the risk of death. It leads to keep patients in the ICU on the ventilator for a long time. It leads to keeping the patients in the on the ventilator for a long time. It has been shown that it actually increases the stress for patients. So increase oxygen consumption, etc. So this is from one study that looked at deep sedation versus not deep sedation, and these are called survival curves. And it shows statistically that patients who are heavily sedated, they do worse. They're more likely to die. It's not a joke. So it's a serious business. So please, very important. I think all of us need to go to our units and work on this issue. Over sedation is harmful for patients. And not only harmful in terms of death, but it's harmful psychologically. So this is a study where it looked at the mental health of patients. And they found that the patients who are deeply sedated had more post-traumatic stress syndrome. They are more likely remembering. They will have memory problems. They will have anxiety. They are more likely to have depression when they recover from ICU. And I think many of us have seen survivors of ICU. I think this is, we live within ICU. Sometimes we don't see what happened after discharge. But some of the patients who went through critical illness, you could see even their personality sometimes, they're a little more depressed. They want to talk. It's been very stressful for them. But clearly, giving too much sedation contribute to this, unfortunately. So giving too much sedation appeared to be a factor in this. So good news, so bad news is too much sedation is bad. But the good news is that we can do something about it, okay? So the good news is this something can be changed. So this is a study where they looked at sedation protocol. What are these lines? So sedation protocol, and found that when nurses implemented a sedation protocol, this led to reduction in mechanical ventilation duration, reduced length of stay, reduced the stay in the hospital. So it is associated with improved outcomes when we implement a nursing-led protocol for sedation. So this is some of the numbers. This is another way. So maybe you could say nursing in our unit. Maybe you could say we want pharmacists to help. So in places where you have a clinical pharmacist who can help. So this is a study having a clinical pharmacist help in the project. And they found that intervening by clinical pharmacists to reduce sedation led to reduction, for example, here, lorazepam dose, fentanyl dose reduced from 400 average to 102. So like reduce it by 75%. And that led to reduction in mechanical ventilation, length of stay, and hospital length of stay. So, so what can we do? What we can do, there are different ways of reducing sedation, but probably the most accepted one is to stop sedation daily, sedation interruption. And sedation interruption, meaning patients who meet certain criteria, you stop their sedation in the morning, just stop it. And you'll find that many of them will not need sedation at all, actually. And maybe they can be on an extubator. So like in this study, stopping sedation until the patient awake and restart if needed, 50%, was associated with a significant reduction in length of stay. And there are many, many studies done on this topic. So this is, again, duration of mechanical ventilation is reduced. And I'm sure many of you have seen this. Sometimes somebody is not expected, you stop sedation and he's extubatable. It happens very often, right? Very often. Now, the other thing which is important in this project, and that's why it's CUSP, why it's multidisciplinary, that we need to synchronize our efforts. So stopping sedation should be done in conjunction with weaning. So you cannot have weaning if the patient is heavily sedated. And there's no point if you stop sedation and the patient becomes agitated all over the place and you didn't take the opportunity to see if he's weanable. So this, for example, this is called ABC's trial, where they paired sedation and ventilation weaning together. So we want to do them together. We want to stop sedation and soon after the patient wake up, do spontaneous awakening trial. So this is called awakening and breathing control trial. And this is really a landmark study which showed that what happened is it reduced the duration of, the duration on the ventilator by 3 days. So this is ventilation-free days. So longer ventilation-free days is better. More patients were extubated. Mortality was reduced from 58 to 44%. Patients in coma were less often. Patient who had delirium was about the same. Death at 1 year was reduced by 14%. So by doing this, reducing sedation, stopping sedation, and awakening trial, we were able to reduce mortality and many, many other outcomes. So this is another way, just graphically, to look at the difference in mortality. So this is really something important, something relatively easy, and it doesn't cost anything. It's actually, you save money. And it's really good for patients because it will improve their outcomes and improve their even psychological outcome. So this is the trials, but there are many people who took this forward and implemented like what we are trying to do in NESAM as a quality improvement project to see if that makes a difference. So this is a cohort called CDC, Rethinking Critical Care. It's a collaborative that try to implement the project. And this is done in 20 ICUs. I think we should be proud that we have 78 ICUs in the NESAM project. So it's much bigger than this one. So they have 20 ICUs. 12 of them have full collaborative, so they contributed fully to the project. And we are hoping that we'll get more of our ICUs contributing. And what they've done is what we are trying to do, implement spontaneous awakening trial and spontaneous breathing trial. And as a result of people good work in all these units, there was 3 to 4-fold increase in implementing spontaneous awakening trial and breathing trial. How did that affect patient? That reduces the risk of ventilator-associated events by 35%, and reduced the IVAC by 65%. And there were 8 ICUs that did not do anything. They just collected data, but they did not intervene, and there was no improvement in these units. So it was the units that implemented the project, they had big improvement in their patient outcomes. So this is another project. Number is 702 ICUs in one of the states in the United States, in Indiana. And they implemented spontaneous awakening trial and spontaneous breathing trial. And what that resulted in higher RAS level by 1, so patients were more awake. That reduced delirium by 11% and reduced coma by 6%. طبعا in our collaborative NESAM, our number of patients are going to be in the thousands. I mean, here's 702, but here we're going to see a huge number of patients. So in January alone, last time we checked, we have 5,000 patient days. Well, it's not 5,000 patients, 5,000 patient days. But probably by now it will be much bigger, which means you're going to make big impact on many patients. I mean, even if we do 10% difference impact, it's going to be because number of patients is huge. It will have a huge impact. So really, I think it's important to take this forward. This is another collaborative, again, similar collaborative, and you could see many of these collaboratives done in the United States. fewer done outside. So I think we should be proud of having this big project done in Saudi Arabia, 78 ICUs. But we need all these ICUs to strongly contribute data. So here they have 51 ICU hospitals in Michigan in it's called Keystone ICU Initiative. They implemented SAT and delirium screening, and that led to what is the result? When they stopped sedation, when they did weaning, it resulted to 3.5 more likely patients were able to be mobilized. And we know mobility is good. So when you stop sedation, patient is able to sit, patient able to stand and walk and have exercise, and that improve the patient outcomes. So what they concluded that the whole is greater than the sum of the parts. In other words, the impact of spontaneous breathing trial alone, there is impact for spontaneous breathing trial. There is impact for spontaneous awakening trial. But if you do them together, you'll have much bigger impact. If you do them with mobility, you're going to have even bigger impact if you do them all together for the same patient. Is that clear? That's why you are bundle. It's a bundle, and that's why we want to do it collaboratively, because otherwise it's difficult to implement. In a busy unit, we need the nurses and RTs and the physiotherapists work together on doing this. So this is meta-analysis, looked at 21 studies about this bundle, and they found that it improved the delirium, people did organizational changes, and I see many of the ICUs have developed custom team. That's what we want, organization. So we're making a team to make an improvement. And so what people see some of the statements mentioned by people, and I'm sure many of you have mentioned something like this, similar, that sedation is stopped only for a brief period, then sometimes a few minutes, and then you resume it back because the patient starts to move. And the doctor on call or the nurse on duty didn't want the patient to have any movement. And this is a culture we need to change, because it's okay the patient moves. I mean, we want him to move. We want him actually to be weaned and extubated. So the goal is not to keep him sedated. And this culture is something we really need to change in our units. So the difficulty, the chat. Okay. So the challenge with sedation, why sedation is so difficult? How to move this window? You see this window? No? Okay. So why is it so difficult to change sedation practice? I think the main problem is assessment of sedation. Internet is weak. The main problem is the assessment of sedation. So, and we need an objective way of assessing sedation. So some people in our units use GCS to assess sedation, but this is not the way to assess sedation. Huh?
Sound is not. I will connect mine. So disconnect. It's sharing this one here.
Security key. Sound? Okay, so the issue with sedation, sorry, we are just trying to improve the connection. So the main issue with sedation, I think we need to work on it all, is the way to assess sedation. So sometimes we see sedation assessed by GCS. And GCS, let me tell you, is not to assess sedation. Assessment of sedation is not by GCS. GCS is for level of consciousness, necessarily meant for traumatic brain injury. People use it outside this, but it's not for sedation. The validated ways to assess it, as recommended by guidelines, is either RAS or SAS. So let's talk about RAS, because this is what we are using in the NESAM project. So awake patient will have a score of 0. Okay, alert and calm. Normal person. So 0 is the normal, right? It's calm and alert and calm. Plus values up to +4 is agitation. With +4 is the most very agitated patients. So combative, violent, etc. Hopefully that will be very few patients. And the minuses are sedated. -5 is deeply sedated, unarousable. So what we want our patients to be between 0, -1. I think that's the range where we like our patients for most part. However, of course, some patients who need heavy sedation, like traumatic brain injury, you probably need them to be -4, -5. It's okay. Somebody with ARDS and on neuromuscular blockers, you want them to be heavily sedated. But these are exceptions. Most patients, we should try to give them less sedation. The other problem with sedation is sometimes we start patients on certain dose and we leave it as is for days. This is not good. What we want is to titrate it to the effect. So if you want an effect of sedation of 0 or -1, then once you reach, if the patient was agitated, you reach this level, you should start to come down on sedation. Otherwise, it will accumulate. Our population is, there are some special points about our population. We have too many patients who have renal failure. It's common. It's really more common than US, and so common. It's very common that we have obese patients. We have a lot of old patients, increasing number of old patients in our units. So when you give them high dose of sedatives, it will accumulate for days and days and days. And then you stop it and the patient doesn't wake up. So there are certain risk factors you need to be worried about them. One is renal, obesity, because lots of the benzodiazepine, for example, accumulate in fat tissue. So when you stop sedation, they still have a lot of storage, a lot of benzo in their body. Patients with liver disease because they cannot metabolize it. And old patients, obviously, they are very sensitive. The other issue, which I think it's a common problem in our practice, at least in our unit, I could say for sure, is the use of fentanyl. We use very high dose of fentanyl. So fentanyl also at very high dose is not good. It's like midazolam, so I think we should use just for analgesia and then reduce it as soon as possible. And if you can use PRN doses, that's better. So I would go first, no sedation. So a patient doesn't need any sedation, that's the best way. Second, my second choice, give him PRN. If you can manage with PRN, that's okay. Third, if I can't do it, use something short-acting, maybe propofol or Presdex if you have. And heavy sedation should be very last option, very last option. So this is what I just mentioned. So sometimes we hear these terminology, but they mean the same. Spontaneous awakening trial, meaning sedation interruption, means sedation is sedation, means sedation vacation. So people use the same words, it's the same meaning. Spontaneous awakening trial, means weaning trial, right? So just some terminology issues. So this is the guideline. The PAD is pain and analgesia, and delirium guidelines. That the guideline says we should maintain light level of sedation in our ICU patients because it's associated with better clinical outcomes. Light sedation increases the physiologic stress response, but is not associated with increased incidence of myocardial ischemia. The association with depth of sedation and physiologic skill remains unclear. And generally, guidelines recommend light, not deep sedation, and recommend daily sedation of interruption or a daily target level of sedation. So what we need as physicians and also as nurses to have a target level. So we should agree on, for this patient, what's the RAS we want. When you prescribe propofol, doctor, what's the RAS, what you want? RAS -5 or -0 or 1. So give me a level so I can target titrate it to this level. So we should choose a target level and then try to achieve that, and always try to keep it at the target, not lower than the target. There are many ways of implementing protocols for wake up and breathing trials. So this one of them is that you assess every day, every 24 hours, do a screening whether the patient sedation can be stopped, and if the patients meet the criteria for spontaneous awakening trial. So this will, there are details on this one. Make sure he doesn't have severe traumatic brain injury, not severe ARDS, not neuromuscular blockers, and he has low FiO2, less low PEEP. And if he meets this, then by objective criteria, you can stop sedation, right? Then you should stop it. And if he does okay, then you should move to spontaneous awakening trial if he meets the criteria for this, and then perform spontaneous breathing trial, and if he pass, you extubate. If he fail, you put him back on the ventilator, and if need to be put on sedation. So each unit should come up with their protocol for implementing SBT and SAT. So for example, this is an example of SAT protocol. Just make sure the patient doesn't have active seizures, no alcohol withdrawal, no agitation, no paralytics, no myocardial ischemia, no intracranial hypertension. So if he has none of this, then sedation can be stopped, yes? If he has anxiety, agitation, or pain, became tachypnic, desaturated after his sedation, then this SAT failed and you can resume sedation. So I think creating protocol for this within the unit, and again, we're going to put the link on the website so you can utilize this to build your own protocol if you want. So when you stop sedation, why patients sometimes fail attempts to stop sedation? This study showed that it's most commonly is agitation, sometimes tachypnea, hypoxemia, respiratory distress, very rarely is arrhythmia or myocardial ischemia, very rare. So the guidelines also says when you want to start sedation, don't restart the same dose. Try lower dose maybe. Try half of it and titrate to the goal. And maybe consider bolus if sometimes become patient very agitated, you have to give him a bolus to put him calm again. Spontaneous breathing trial. So this is an example of spontaneous breathing trial. You assess the patient, has no agitation, saturation is good, FiO2 is low, PEEP is low, he's not on pressors, he looks like comfortable on the ventilator. Then you put him on press support trial, and if he does okay, then consider extubation. If he failed because he became tachypnic or bradypnic or hypoxemic or looks like distress or mental size changes, then you abort the spontaneous breathing trial. Very simple, and I would suggest that you try to make one simple. I mean, sometimes I've seen complicated ones, very complicated. So it's really the concept, understand the concept behind this. It's very simple. So I think when we address this, you're gonna have to consider concerns by the staff. I think we need to discuss it like this. All of us are professionals trying to do the best for their patients. And I think the best way is to discuss the benefits of reducing sedation, the harm of sedating patient too much, the harm of keeping patient on the ventilator, and try to all of us be on the same page for this. Understand the concern about workload. Yeah, we don't have enough people. But is the answer for this to keep patients sedated, keep them on the ventilator? This doesn't make a lot of sense, you know. So I think we need to discuss it. But this is the best I can the best solved at the unit level. Each unit should try to address this issue locally to make it best. Fear of we are in a subsedation because we have patients self-extubated. And the answer, maybe, possible. It is possible that sometimes when you subsedation and you're using lighter sedation, you may have some patients who self-extubated, but maybe the answer is to try to put them on a weaning trial before this, so they will not self-extubate. You extubate them by protocol, right? And the answer solution for not having self-extubation definitely is not to sedate patients. I mean, this is, yeah, you solve the issue of self, but you're adding another harm by sedating patients. Does that make sense? So the answer, yeah, we're gonna have, but the other issue, self-extubation, majority of self-extubation actually patients do well. Patients who are good enough to get their tube out, vast majority actually they do okay. So yes, we should worry about self-extubation, but we should understand why is this happen, and maybe we should do weaning trial before. So this other one that we always do, let's give the patient one more day. I think clinical judgment here. Maybe it's too late in the day. Sometimes, sometimes justify, sometimes not justify. But I think we should address it on an individual patient level. I think proper timely extubation require a team, actually, and you see this at the bedside. When you have good collaboration between the doctors, nurses, and RTs, the outcome is better. It's more organized. Everything is done in timely fashion. Do it timely. Try to do this early morning. It's a good time usually. We need the respiratory therapist to speak up in rounds. We are here all for the patients, right? So, and the nurses also. So we are here. We want the RT to talk on rounds, nurses to talk on rounds. We need to keep eye on length on the ventilator. It's not a good thing. Patients who are stable in the ICU, they are the same every day. Is that good? It's bad. Patients should be improving every day. They should not be the same every day. Patients who are the same every day is not a good sign in the ICU. Patients should be every day better than the day before. Should have a step forward. So we don't want to keep patients same every day. Maybe you should think about putting extubation rates that we should be proud of doing extubations. I mean, I got a WhatsApp today this morning. We extubate 6 patients in surgical ICU. This is amazing. So put in WhatsApp, good. So I think we should be proud of it because I think this is good for patients. This is our goal. We should have our goal. Getting patients off the ventilator is a goal. Actually, getting patients out of the ICU is the goal. Getting patients home is the goal, because that's the normal thing. And that's why this website, where this is presentation from, it's called ICU Liberation. Not even mechanical ventilation. ICU Liberation. We want to get the patient healthy. We want them to get back to normal, out of the ICU. And I think this is a whole goal of the NESM project. So, in summary, doing spontaneous awake trial and spontaneous breathing trials is likely to reduce days on the ventilator, reduce the time to weaning, reduce reintubation, reduce delirium, reduce length of stay, reduce in the ICU, and reduce length of stay in the hospital. And there are other slides. I mean, we're going to give you the link so you can look at them. So we have some questions, and if people want to have more questions, can put them in the chat. Okay, is the patient, great question here. So is the patient on fentanyl? Would that be considered sedation or on sedation or not on sedation? The patient on fentanyl, is that sedation or not sedation? sedation. Nursing, what do you think? Depends on the dose. So if you, fentanyl has multiple properties, right? It's if you give it in the right dose, it's analgesic. So analgesia is first, but if you give a lot of it, you knock the patient out. So if you are giving fentanyl and the patient is not awake, so this is not really analgesia anymore. This is sedation. So the answer most of the time is if you're giving infusion, I would say this is sedation. Analgesia will be small dose, patient awake, just having no pain. This is analgesia. But if the patient is out of it, this is then sedation. And I think it's under-recognized in the literature. The harm of this is as bad as fenmidazolam. And sometimes we give a lot of fentanyl. So it's a very great question. Next question, in early mobility, when we want to put the patient, put the goal for RAS, NS meaning not sedated, or we will put the target even the patient without sedation. Who can answer this one? So this the target of RAS. So we should have target for sedation for all patients, right? It's like it's like think about norepinephrine. When you prescribe norepinephrine, there is a target. You say give norepinephrine. The target. No sound. Sound. No sound. Sound. You hear me? So when you prescribe norepinephrine, you prescribe a dose of norepinephrine that is titratable up and down, right? Typically, that's what we do. And we say maintain mean arterial pressure above 65. We put a goal, correct? When you give dopamine, will be the same. You are putting a goal. You are giving the nurse a range, and you are giving a goal that maintain blood pressure above this. Should be the same for sedation. We give you a sedation infusion, and we want to say that we want RAS of 0. So RAS should be prescribed for all patients who are getting sedation. So when you prescribe sedation, you should tell me what's the RAS. So if the patient is, you want to mobilize him, I think should we have a RAS also, I guess, if I understood the question correctly. And then, of course, if you want to mobilize the patient, you like him to be awake. So you want to have RAS of 0. Any other questions? Any questions from here? Light sedation. Light sedation is not only minimizing sedatives to achieve your target RAS. Is that a question or a comment?
Yes, a comment.
Assalamu alaikum.
So, Dr. Ahmed, let's answer this comment here.
This is my comment actually, because as you had mentioned in your slides, actually, a worry of self-extubation, it is something considerable actually. So I just want to comment, it is not only going down with your sedatives to achieve your target sedation. This is not only like that. It is actually, if you can notice, even the literature, it is going in parallel with family engagement, with mobilization. So just my message and my experience for the others, kindly, if you are going with light sedation or targeting RAS 0 or -1, you have to be beside your patient. You have to communicate him with surroundings. You have to keep in your mind that not only going down with the sedatives, right? Otherwise you will have self-extubation. So this is the message I want to just to convey to them.
Agree. I think for some patients this is needed if the patient is agitated, but many patients actually are ventilated well without any sedation, and there are studies looking at no sedation, 0 sedation. So yes, I think we need to be precautious, but if we are over precautious, I think we'll end up back to square one. We'll be sedating everybody. The best is we need to reduce sedation. So there are 2 approaches. Approach number 1 is this daily interruption of sedation, okay? There are other approach which is using sedation protocol, which is weaning sedation gradually, etc. And there are pluses and minuses for each one. But I think the best, if we want to avoid, certainly I think I will fully agree with your precautions about self-extubation as much as possible. But if we coordinate this weaning, coordinate the sedation with weaning, then this will be limited. So don't stop sedation and the weaning trial is done 5 hours later, then you'll have more chance. But if this is done simultaneously and the patient was assessed for possible extubation in a timely fashion, I think this chance will be reduced. Can I get back? So if the patient is on fentanyl infusion, will I consider it on sedation? The answer, I would say, if it's on fentanyl infusion, say yes. There's a question regarding target sedation, how I enter if it's a range. Should I enter the lighter limit? I think that would be reasonable. So if you are saying, if you are telling the nurse that you want -1 to 0, and you enter at 0, I think it's reasonable. Question about, okay. Sister Chitra, thank you very much. Great questions. Any other questions? Okay, so I'm collecting data. Okay, I'm collecting data for our project, but I'm facing some issues. For example, sedation scale, the options are RAS or SAS, not used in the unit. We're using RAS, but the patient is not sedated at all. The other issue is the patient is not sedated. The following question is SBT done when sedation off. We're using grass, so we are using grass, which is good. Yeah, patient not sedated, so put 0. So the doctors want him to be awake, right? Want him calm. So that's why you are not using sedation. So your goal is not to sedate the patient, so that means RAS of 0. Then that will allow you to go on to the next data collection. Any other chats? About ECMO. Should we exclude like HFO? Yes, I think so. I think the ECMO are really, really small subset of patients, and their ventilator parameters and weaning are completely not applicable. So I think for the big picture, it's like high frequency will not include them. Excellent questions. I think we have 2 minutes left. So we're gonna just mention the plan for the patient safety survey. Ahmed or Abdullah? Ahmed? So I think we're almost close to send it, right, Abdullah?
Okay, thank you, Dr. Arabi. So we are now collecting the emails. So we need all of the emails for all healthcare workers within all of the units, because the culture is formed by the healthcare workers within these units. This means the nurses, the physicians, and the respiratory therapists, and also the pharmacists. So whoever in that unit, we would like to get their emails. So we will enter to the system, and it will be sent to them once we completed all of the sites. And this message need to be communicated to the frontline staff, so they will understand that this is not a spam message.
Yeah. So we want more, at least 60% response.
Yeah.
Ideally 100%. We should have everybody respond, because that's very important. I think we are thinking about maybe making newsletter for this project.
Yeah.
Where different units can put some news, their team formation, some experiences. So we'll circulate and we'll think about. We'll like to have input from different units. Any other comments before we stop? So this is fantastic. So again, just a reminder about putting the data, a reminder about going to the website and make a use of it, because I mean, this at the end is what this is what's for, is that utilize the data to guide the change in your unit. And as I showed you in the beginning, there is certainly area for improvement in many of these aspects. So please access it and add your data so it will have something meaningful for you and for the whole project. And with this, I thank you very much for attending.
Stop the recording.